atopic dermatitis. Atopic dermatitis is the most common form of eczema. By definition, atopic dermatitis is a chronic relapsing inflammatory skin disorder. It's due to type 2 inflammation, which is a combination of genetic susceptibility, immunological factors, and environmental factors which have an epigenetic impact on the genes. According to this triad, patients who fulfill the criteria needed for definition of atopic dermatitis, which include itching. Itching is a hallmark. Without itching, it's not atopic dermatitis. It's eczema to any other cause. It might be something like irritant eczema. It might be due to immune deficiency, for example, but it's not atopic. Atopic means that there is itching and typical morphological distribution of the lesions according to each age group, and we will describe it in the next slide. In addition to starting of the lesions at early age, like before the age of 2 years, for example, it's with a diagnosis, but it's not necessary to diagnose atopic dermatitis, as well as the presence of family or personal history of other type of atopy, like asthma, like allergic rhinitis, either in the same patient or in one of his family members. Dryness of the skin is one of the supportive manifestations. In addition to other manifestations which might associate the presence of dermatitis or may be absent. The typical distribution of eczema to diagnose atopic dermatitis in infants is first appear in the cheeks and in the extensor surfaces. When the patient grows up to the school age, the distribution turns to be in the flexural size rather than the extensor surfaces, and in the adults it's more in the flexural size, and in the hands and feet rather than being in the extensor surface. Atopic dermatitis usually spares the axillae and spares the groin area. When you find a patient with eczema in either the size, axillae, or the nose, nasal tip, or in the groin, please consider other differential diagnoses. In patients with atopic dermatitis, we have to investigate carefully the shape of the skin. Is there redness? Is there dryness? Is there keratosis, thickening of the skin? Is there exfoliation? Is there blisters? Is there bleeding? The itching marks? All these go with the eczema of atopic dermatitis. Those patients should avoid the triggers as much as possible. The triggers might be irritants, and all irritants will increase the presence of eczema or dermatitis, whatever the underlying etiology, like the climate changes, like the type of clothes. All patients with atopic dermatitis or eczema in general should wear cotton clothes. The addition of any cosmetics on the skin or detergents or irritants will increase the severity of eczema, in addition to the stress. All these are considered as irritants. So any patient who is exposed to these factors, to one or many of these factors, will have exacerbation of his eczema. What about the allergens? In some occasions, atopic dermatitis is triggered by certain allergens, which might be food allergens, like milk, like wheat, like eggs, fish, nuts, etc. And it might be aeroallergens. How can we detect these allergens? Through certain investigations like specific IgE screening testing, either in the serum or in the skin. Whenever we reach the culprit allergen, we have to avoid it as much as possible to decrease the flare-ups of atopic dermatitis. The main problem of atopic dermatitis is that it starts as what's known as the atopic march. Usually the infants who are defined to be atopic later on in their life, usually they start with eczema in their infancy, followed by appearance of allergic rhinitis and otitis media, followed by appearance of asthma. And in literature, they found that there is an association between atopic dermatitis and asthma in up to 50% of patients with atopic dermatitis, and 75% of atopic dermatitis patients have allergic rhinitis. The main problem and the main issue in atopic dermatitis is what's known as the itch-scratch cycle. When the patient has dermatitis, he has itching. The itching will open an access to more exposure to more allergens or irritants, and the itching itself will increase the inflammatory reaction, which from the start is abnormal due to genetic predisposition and abnormality in the immunological response to exposure to certain irritants. So more scratching will lead to more inflammation, and more inflammation will lead to more itch, and more itch will lead to more scratch. This will end with us to this picture that there is more access to microbes and more access to the irritants. In this occasion, there will be more exposure of the inflammatory cells to induce type 2 inflammation, which is apparent inflammatory reaction. It's not the usual reaction. The type 2 inflammation depends on that when the patient is exposed to certain irritants or microbes, it will react through the antigen presenting cells through T helper 2 cells. T helper 2 cells will induce the oversecretion of certain cytokines, potent pro-inflammatory cytokines like interleukin 4, interleukin 5, interleukin 13, which in turn will stimulate the B lymphocytes to produce IgE, will induce the recruitment of more eosinophils, will induce the recruitment of more basophils, and stimulation of other potent inflammatory cytokines like interleukin 17, interleukin 31, interleukin 32, interleukin 33. All these cytokines will lead to many cascades which are harmful to the skin, like the destruction of the skin barrier. Peregrine and ceramide are the main components of the proteins and lipoproteins in the skin barrier. They will be destroyed, and this will lead to more access to more pathogens and irritants, as well as the repair of the skin will be impaired, leading to more hyperkeratosis and fibrous tissue formation. Because of this, studies were investigating the specific nature of atopic dermatitis being not just an allergic disease. It's not just a food allergy. No, it's a host environmental interaction leading to type 2 inflammation through type 2 innate lymphoid cells, basophil mast cell stimulation, T helper 2 cells, which will induce the interleukin 4, 5, 13, and 31, the main players in this cascade. Type 2 inflammation will destroy the barrier of the skin, leading to destruction of the intracellular structural proteins, extracellular lipids, and junctional proteins, leading to enhancement of more microbes. On the top of the list comes the Staphylococcus aureus. Atopic dermatitis is not necessarily being immune-mediated. It can be immune-mediated, IgE or non-IgE mediated, and can either be non-immune mediated. The same patients may present to us with any of these stages of the lesions. The lesions might be acute in certain part of his body, and subacute in another part, and chronic in a third part. The acute lesions are known with their redness, itching, and they have distinctive borders. When it becomes and when the lesions are chronic, the patient has hyperkeratosis, fibrosis, deepening of the skin marks, and what's known as lichenification. These are pictures of patients with chronic eczema, severe form. This is the lichenification and crustaceans and the deepening of the skin marks, as you see. Another problem with atopic dermatitis, not only the itching, but also the disruption of the normal life pattern, the disruption of sleep, quality of sleep. So the atopic dermatitis was found to significantly reduce the quality of life of patients and their families because of the risk of anxiety. And when the patient gets older, he has anxiety problems. Some of them go through depression, suicidal attempts, and in some occasions, they become aggressive. They fail to do peer relationships. Some of them have enuresis because of the anxiety and distress, and the disruption of the quality of sleep will by default hinder or impair the growth and development of those patients. As well as the effect or the impact of atopic dermatitis on the school achievement or the work achievement in the adult patients. To assess atopic dermatitis, the assessment is totally clinical. There is no single investigation to diagnose or score or escalate the progression of atopic dermatitis. So, however, you use the SCORAD system, severity scoring index of atopic dermatitis to assess your patient or follow up him, or the AZ or any other scoring system, you have to put your scoring system that you will initially assess your patient, and then you will follow him on regular intervals. It might be every 2 weeks initially, and then it might be every month or 2 months to assess the score of redness, swelling, oozing of crustaceans, and the scratch markings. And according to the shape of the lesion and the distribution surface area affected of the skin, you can put your patient on the score and you can assess where he is standing. In addition to these physical signs, we have to ask about the quality of sleep of the patient and the intensity of itching. The patient may put his own score 0 to 10, 0 is being very nice, 10 is being very living in hell. This is the shape of the score. So here we calculate the surface area affected, and these are the erythema and crustaceans, oozing, lichenification, dryness of the skin. We will score them from 0 to 3, and we will ask the patient about his satisfaction, about his lesions, about his itching, and the quality of sleep. Finally, we do our equation and calculate the SCORAD. Finally, if it's less than 25, so the patient has mild lesions. If it's 25 to 50, so the patient has moderate lesions, and if it's more than 50, the patient has severe lesions. This is the easy, it's more complicated than the SCORAD. How do we manage atopic dermatitis? Lines of management are two-fold. The classic lines of treatment, which depend mainly on managing the skin infections, moisturizing the skin, treating the inflammation, reducing the itch as much as possible, and there are new insights and new updates in the management. The management is a stepwise approach. There is the European guideline, there is the American guidelines, all of them agree to this stepwise approach. In the first stages of the eczema, and when you see your patient for the first time, if the lesions are mild or tolerable, we can use just topical medications like moisturizing the skin, or putting topical anti-inflammatory medications like topical steroids. If there is no response, please add topical tacrolimus, because it will decrease the inflammation, treat the infections, avoid the triggers. What about the patients who are not responding, or who are severe from the start, or who have progressive skin lesions, or who have disturbed quality of life? In this occasion, we will need to go for the severe forms and the lines of treatment which are non-topical. Let's go through all of them. What's new about the skin moisturizing? The usual in the skin moisturizing being the cornerstone in treating atopic dermatitis, using the emollients or those materials who have occlusive patterns to keep the skin well hydrolyzed, moisturized, and to avoid dryness. What's new in these medications? The barrier repair agents, which contain the proteins and lipoproteins which are needed for the formation or the repair of the barrier, skin barrier. Adding these items in addition to the moisturizing the skin will lead to better results, and this is still under studies, still in phase 2 study. What about the skin anti-inflammatory agents? What we had till about 10 years was topical corticosteroids, topical calcineurin inhibitors, topical tacrolimus. Topical steroids in infants, we use low to moderate potency steroids. In others, we can use high potency steroids, but take care of the side effects, take care of the skin infections. In some occasions, we need to use short courses of systemic corticosteroids. Those who are not responding to topical corticosteroids, they use topical calcineurin inhibitors. They should not be applied before the age of 2 years. They should not be applied to patients who are suspected to have immune deficiency or to skin which is infected, and not to be combined with phototherapy. Take into your consideration that calcineurin inhibitors are questionable for the risk of skin malignancy. What's new was the topical phosphodiesterase inhibitors, which are FDA approved currently to be used for age 3 months and older. They act through selective inhibition of phosphodiesterase inhibitor, which increase the intracellular cyclic AMP. Cyclic AMP is the opposite of the ATP in its action. It will suppress the overproduction of the pro-inflammatory cytokines, interleukin-4, interleukin-5, tumor necrosis factor, and interferon alpha, gamma. This will decrease the inflammation of the skin in general. The other drug is the topical JAK inhibitors. JAK inhibitors act through suppression of the enzymatic reaction responsible for the inflammation. Topical JAK inhibitors were approved to be used in Japan by the year 2020 for treatment of adults, but not pediatrics. Up to now, we are still in phase 2 studies. It has a potent and rapid effect on itching, repairing the skin barrier, and the hyperkeratosis. Topical calcineurin inhibitors, not to be used for chronic long-term application. Not all patients should be older than 2 years. Application of topical calcineurin inhibitors should be 2 to 3 times per week at size prone to exacerbation to reduce relapse. Phosphodiesterase inhibitors, as we say, it's approved by the FDA to be used for ages older than 3 months and approved by EMA to be used in children older than 2 years. Typical JAK inhibitors are still in phase 2 study, and it's not approved up to now to be used in children. What about the immunobiological therapy? The use of conventional therapies like steroids, systemic steroids, or other immunomodulators like azathioprine, cyclosporin A, methotrexate, and mycophenolate mofetil, they are recommended for short-term use in children with atopic dermatitis, not to be used for longer durations. But there is no single recommendation determining the dose and the duration with safety margin to be used in patients with atopic dermatitis. So we don't know till when we will use cyclosporin A for those who have atopic dermatitis. We have to follow the side effects, we have to follow the nephrotoxicity and the possible ototoxicity. This goes for the other immunomodulators. That's why this opened the door for the new immunobiologics, which are monobiologics or biological therapy, which target certain cytokine or certain single cell, doing the effect with the least side effects, the least possible side effects. The single biological therapy, which was approved by the FDA and EMA to be used for cases of severe atopic dermatitis in children, was dupilumab, which is fully immunized biological therapy targeting interleukin-4 alpha and interleukin-13 alpha receptors. It was approved to be used for children older than 6 months by the year 2022. Other immunobiologics are still under research, such as inhibitors for interleukin-31, interleukin-13, interleukin-22, and systemic JAK inhibitors. Let's go rapidly through these. Here is the skin. The impaired skin barrier due to genetic predisposition and abnormal inflammatory reaction when exposed to certain environmental factors. The stimulation of Langerhans cells and dendritic cells will stimulate the T helper 2. T helper 2 in turn will stimulate pro-inflammatory cytokines. Interleukin-4, 5, 13, 31 are the main players. So when we use dupilumab, we are targeting these cytokines, interleukin-4, interleukin-13. This will close this part. So this will close the door to stimulate B cells for more production of IgE. This will close the door for stimulation of eosinophils, as well as stopping the bad input on the barrier disruption of collagen, hindering the differentiation of the skin, destruction of the lipoproteins. This is the role of dupilumab. Whereas interleukin 23 is here, interleukin 17 is here, interleukin 31 is here, but these are still under study. Dupilumab is fully immunized, as we say, so immune tolerance is almost 0. There is no antibodies are formed by the body regarding this medication, and the studies were done and showing a good impact on the quality of life and atopic dermatitis signs and symptoms, with a good or acceptable safety profile. many studies in this review article meta-analysis. They studied 25 clinical practice guidelines. 1/3 of them have recommended dupilumab to be used as a second line after topical measures, and the other 2/3 of studies have recommended dupilumab to be used after phototherapy or even after trying the immunomodulators. In my country, in Egypt, the drug is accessible since November 2021, and it's pending the approval by the national insurance. I think in the Gulf area, it's available and it's insured. I don't know about the other countries. What about the duration? Till when will we continue in dupilumab? The initial studies up till now have recommended the use of dupilumab for up to 1 year, and this will give safety margin for up to 6 months before going through relapse, which becomes milder relapse. Interleukin-31 inhibitor is a selective monoclonal nemolizumab. It's a selective monoclonal antibody for interleukin-31 alpha receptor. It's still in phase 2 studies. Up to now, there is significant improvement in the severity and itching of atopic dermatitis. The initial side effects are related to exacerbation of dermatitis, some upper respiratory tract infections, and mild increase in creatinine level in adults. Interleukin-13 inhibitors, they inhibit the interleukin-13 receptor 1 alpha. They are still, the two drugs are still in phase 2. The initial results are fine as regarded the impact of the drug with safety profile. We hope it's available very soon. Interleukin-22 inhibitors, it acts on the interleukin-22, which has a key role in the barrier dysfunction and epidermal hyperproliferation in patients with atopic dermatitis. Up to now, it's still in phase 2 studying. It has good results as regards the severity of cases of moderate to severe cases of atopic dermatitis with a good safety profile. JAK inhibitors, they act by inhibiting the activity of one or more enzymes of the JAK family, thus interfering with the JAK-STAT signaling pathway, blocking inflammatory cytokines and growth factors. Several oral JAK inhibitors such as baricitinib and abrocitinib and others are currently being studied for the treatment of children with atopic dermatitis. Baricitinib so far have gained approval by FDA to be used in adult patients with atopic dermatitis, but still seeking approval for the use for being used for children. My key message: atopic dermatitis is the most common type of eczema, affecting more than 9.6 million children in the United States, which is a huge number. Atopic dermatitis is a chronic relapsing condition that impacts the quality of life of the patients and their families. When to use biological therapy in patients with atopic dermatitis and how to select the most convenient for the patient, this needs a well-experienced and qualified team rather than a specialist. Thank you, and let's together put an end for their segment. Thank you.
Thank you so much for the wonderful presentation. Do we have any questions from the audience for you?